everyone. I'm Yuchao from Shenzhen University in China. Okay, this is my first time to Turkey. So everything is here is wonderful and great. So Alice, thank you very much for your invitation. So here I'm glad to share our recent work. So my topic today is machine learning application in brain disorders. We take a schizophrenia as an example. So we're using machine learning on brain images. So we found 2 schizophrenia biotypes from more than 10,000 individuals. So I have no personal or financial interests to declare. So schizophrenia is a serious psychiatric disorder. So here I'm not going to talk more about what is schizophrenia because there are so many professional clinical research here. But what I want to say is that schizophrenia is a highly heterogeneous disorder. What does that mean? That means this symptom-based diagnosis has a big difference across individuals' diagnosis with schizophrenia in pathogenesis, symptoms, progression, neuroimaging, neurobiology, and therapy. So, a biological subtyping may be a necessary step towards brain sense diagnosis in psychiatry. In brain imaging, patients with schizophrenia have many brain changes. So we call it SLAT. So it is a SLAT atrophy in both cortical thickness and subcortical volume. Okay, this is an enigma results in structural MRI. In the cortex, the most affected regions are located within frontal, temporal, insular, and cingulate cortex. So all of those regions show decreased thickness cortex. But as for the subcortex, the most affected regions are located within hippocampus, amygdala, thalamus, and accumbens. Those regions all shows decreased volume, but in some other subcortical regions, there are increased volume, such as putamen and pallidum. But these changes are not consistent these changes are not consistent individuals with schizophrenia. So one of the potential causes may be the biological variability in schizophrenia. So this is our recent work this year. So we compared the inter-subject variability in schizophrenia patients. We found at the group level average, there is a slight brain atrophy in patients. But at the individual level, the atrophy of each patient is not consistent. We analyzed the data, the MRI data from over 1,000 cases, and we found only about 20% to 30% of patients have the same average, have the same atrophy at an individual level. So that means there is a big variability in patients with schizophrenia. We think why there is a big variability. We think the one cause of variability is temporal variability. But what is temporal variability in the brain? Okay, that means the brain is changing and dynamic progressing. So we can say with a large disease duration, there are progressive reductions in brain atrophy. At the first episode, patients have atrophy only in local regions such as frontal, temporal, and parietal. But at the chronic, the brain atrophy separated to the most of the other regions and other cortex. So our work is to modeling the brain grasses and thinking the potential subtypes in the progresses. So how to make the model? So how to modeling the brain grasses? One regular idea is select a large longitudinal data, but it's too difficult. We need a long time follow-up. So, and for schizophrenia, it is too hard, too difficult to find so many longitudinal data. So we would like to say if we can model it by using cross-sectional MRI data, because it's easy to select and there have much more cross-sectional data. So we found AI methods to model it using cross-sectional data. It's called event-based model or event-based methods. This model and this approach is a machine learning approach. It can quantify a sequence of abnormality in a set of disease-relevant biomarker. So we use the event-based model on brain imagings, so it can estimate the brain atrophy sequence for several brain regions, so we can find the sequence of brain atrophy. And we use a new system model called subtype and stage inference model. So we call it SUSTAIN. It's a new event-based model approach. And what I wanted to say important is SUSTAIN can not only estimate the sequence of brain atrophy, and it also can find the subtypes. Different subtypes have different brain atrophy sequence. And another point is that SUSTAIN required only cross-sectional data. It did not require longitudinal data, but longitudinal data can validate the SUSTAIN results. So here is our data in our work. We have a lot of brain imaging data with a very huge sample size. More than 12,000 individuals. In our first discovery work, we collaborate with more than 10 hospitals in China. Okay, this data includes more than 1,000 patients with schizophrenia. And in our second validation work, we collaborate with Enigma. We finally have data from more than 4,000 patients and 8,000 healthy controls. And this sample allowed us to validate our subtype in Asia population, European population, and North American population. So use this data, we make a SUSTAIN modeling. Here is our schizophrenia SUSTAIN model. So I'm not going to talk more about the model details. I will focus our model results today. So we make a SUSTAIN model, and we found two trajectories of brain atrophy in schizophrenia. They are robust. In the first trajectory, the brain atrophy is observed first in Broca's area and the insula, and then move to the anterior cingulate, prefrontal temporal cortex, and finally to the neurocortex, and finally to the subcortex. This is the first subtype from Broca's area. And for the second trajectory, brain atrophy occurred first in the hippocampus and then moved to adjacent areas, including amygdala and the parahippocampus, and then move to other subcortical regions such as thalamus, accumbens, caudate, and finally to the neurocortex. This is the second subtype, atrophy from the hippocampus. So in our another validation work, we also found the two trajectories using different data and samples from the worldwide. In the Asian population, the patients from China, Japan, South Korea, and Singapore, use these dates. We replicate the two distinct trajectory of brain atrophy in East Asia population and the European population. So we also replicate the two trajectories in the first episode patient population and medication naive population. This finding suggests that the two biotypes with distinct trajectories in the brain atrophy is robust and reproducibility. So we modeled the two trajectories of brain atrophy and found there are two sources at the brain. So they are broadcast and the hippocampus. But we all know the sustained trajectory are not from the longitudinal data. They are estimated from cross-sectional data. So we want to see if the broadcast and the hippocampus are actually the two sources of brain atrophy. So we provide some of the evidence. The first evidence is from longitudinal data. We selected longitudinal data from some of first episode patients. Those patients have 2 times MRI data at both baseline and 3 months at follow-up. So it's a very short interval. But in this data, we found the subtype 1 had the greatest gray matter reduction in the broadcast area at the follow-up. And for the subtype 2, patients had have the largest gray matter volume reduction occurred in the hippocampus at the follow-up. So they are consistent with the SUST modeling results. The two regions, broadcast area and hippocampus, may be the two sources of brain atrophy in the first episode of schizophrenia. And the second evidence is another prevalence study published in Schizophrenia Bulletin in 2021. They found broadcast atrophy may contribute to clinical high-risk conversion to psychosis diagnosis. They found compared with clinical high-risk patients who are not convention, those convention patients have worse brain atrophy in those language area such as superior and temporal and inferior frontal. And the third evidence is another our work. We found broadcast atrophy features may have diagnostic specificity among several mental disorders. We used a method called epicenter mapping. It's a brain imaging method. It can find the epicenter of brain atrophy spreading from one region to another region. So I'm not going to talk more about the epicenter methods. If you are interested, please see our paper. This is our key results. We found broadcast and adjacent areas, including anterior insula, are the epicenter of brain atrophy. This is only in schizophrenia, but not in OCD, bipolar, and MDD. So, and the fourth evidence is that is from another previous paper report the hippocampus lesion may cause psychosis. It uses an approach called lesion network mapping. a famous and a hot approach posted by Michael Fox in NEGM. It found a lesion within brain. Lesion within brain may affect the hippocampus to cause psychosis. Is their results. So another point we interest is that the two subtypes have different in other clinical characteristics. So we measured a total of 330 regional morphometry in cortical thickness, surface area, volume, and subcortical features, and compared their difference between the two subtypes. In briefly, we found the worst reduction in cortical morphometry is located within the superior frontal regions for the subtype 1, but in the temporal regions for the subtype 2. And for the subcortical regions, the volume of stratum is increased in the subtype 1, but decreased in the subtype 2 compared with the healthy controls. This is the main finding in their brain atrophy. So another point, we found the two subtypes have difference in long-term symptoms. We found for the later stage patients whose illness duration more than 10 years, those patients have worse positive symptoms, depression and anxiety symptoms for the subtype 1. Is the subtype 1 may express a worse symptoms in their long-term outcome. Finally, I want to talk about how to subtype one new person to look at their clinical outcomes. We have treated a system model. So using this model, we can achieve individual subtype. So for each new patient, we can input the date, the patient's date into the treatment model. The patients were first classified to which trajectory, and secondly, it will classify to which sub-stage of the trajectory. So it's a two-step subtyping. The first is subtyping to which trajectory. The second is subtype into the sub-stage. So we found some other new data with treatment outcomes. We have longitudinal data from more than 500 patients with schizophrenia. We have their MRI data and their treatment information. So as for the drug medication patients, we found a significant positive correlation between the subtype 1 and the treatment outcomes. And for the TMS follow-up data, we found a significant negative correlation between the sustained stage and the symptom reduction. What does that mean? That means if the patient who located at an early sustained stage, early stage of the sustained trajectory, the patients may have a better treatment outcomes from TMS treatment. So because of the time, more treatment findings you can see in our published paper. So have a summary for this talk. We described two distinct but stable trajectory subtype in schizophrenia. They are beginning at the Broca's area and the hippocampus. The two subtypes have different atrophy patterns and clinical symptoms and treatment outcomes. Antipsychotic drugs treatment may be more effective in the subtype 1, and the TMS treatment may be more effective for the early sustained stage. And these findings suggest a distinct process in schizophrenia. Maybe they are helpful for the future person's treatment in psychiatry. Okay, that's our team and our collaborators. Okay, thank you for your listening.